Good evening, everyone. Thank you so much for being here for our Tuesday panel on healthcare disparities in New Mexico. My name is Manny Crispin, and I'm the first vice chair of the Democratic Party of Bernalillo County. It's very important that we keep and continue working towards advancing health equity benefits for all New Mexicans. An overarching goal of the Healthy People 2020 is to achieve healthy equity, eliminate disparities, and remove the health of all groups. Health equity is defined as the absence of unfair and unavoidable or avoidable remedial differences in health interventions and outcomes among groups of people. Achieving health equity means that all people have the opportunity to reach their full health potential, and it depends on understanding health disparities among different populations and the factors that create those disparities. Thank you again for being here, and I will remind the audience that we will be conducting this with the panelists, and you will all be muted. And if you have any questions for any of our panelists, please submit the questions on the to the panel through the Q&A button. And I would like to introduce to you our chair for Democratic Party of Bernalillo County. It is my pleasure to announce Flora Lucero.
Thank you very much, Manny. I appreciate that. And thank you to each one of our panelists for being here for this important conversation. We need to have these conversations. We need to have these conversations in our homes. We need to have these conversations in public spaces. And as a Democratic Party, we want to be a party that is truly of, by, and for the people. And the only way we can do that is whenever all voices are heard, when all people are at the table. And so I thank you for bringing yourselves here to this conversation and to allow us to be able to hear your voices today, and to also, hopefully, the people who are attending can contribute as well. And thank you, Manny, for leading this effort and for also leading other panels on racial equity. I'd like to thank Ellen Copeland from the West Side Democrats. She was instrumental in putting this panel together, as was Lance Chilton. So thank you very much to both of them for their work on this. And thank you for all you attendees for being here. I appreciate you partaking here and letting us, work together towards something greater for all of us. So thank you, Manny, and at this time, I'll turn it back over to you.
Okay, thank you so much, Flora. Like Flora said, we have a lot of important work to do, and without you, it would be impossible. At this time, I would like to send a warm welcome to our moderator, Sonia Smith, who is a Special Projects Coordinator, Office of the Secretary of New Mexico of Health, and the co-liaison for the Black Women for Biden. Sonia, thank you so much for being here, and it is with great honor that I introduce you. Thank you again.
Wow, thank you so much, Manny. I really appreciate that warm welcome, and I'm just so glad to be here. And I am looking forward to a very informative conversation with these wonderful panel of experts. So I'm going to take a few moments to introduce them, and then I'm going to circle back and have each of them take a few moments to tell us a little bit about themselves. Is that okay, Manny?
Absolutely.
Okay.
Thank you so much, Sonia.
No problem. So I'm going to start with Teresa Gomez. She's a community activist. And then we have Dr. Mario Cruz. Then we have Senator Jerry Ortiz y Pino, Dr. Sara Del Campo de Gonzalez. And I think that's everyone we have on our panel this evening. So again, we're so very glad that you have taken time out of your busy schedules to give us information. So I'm going to go with ladies first, gentlemen, if that's okay. So we'll start with Teresa. Would you give us some information about yourself and just tell us why you're here and why this is important to be taking part in tonight? So if we can unmute her, that would be wonderful. Thank you.
Well, thank you so much. It is quite an honor to be here this evening with you all. I'm Teresa Gomez, and I come from the Pueblo of Isleta. I'm a lifelong resident of New Mexico, and again, just really excited to be here tonight to share some information about American Indian communities in New Mexico, and give you some information about health disparities and really why we're seeing, especially today in the age of COVID, why we're seeing such great disparities within the American Indian community, not only throughout the state, but in neighboring states where you see large populations of Native Americans. And so I don't know if you want to have everyone introduce themselves first, and then
Yes.
we'll launch. Okay.
Yeah, then we'll come back. Yeah, so thank you so much, Teresa. So then we'll go to Dr. Sara, please.
Hi, everybody. My name is Sara Del Campo de Gonzalez. I'm a pediatrician at University of New Mexico, one of our clinics, Young Children's Health Center. So we're located in the International District. And in my other role, I also lead the training and education for all of the pediatricians graduating from UNM's residency program in advocacy and community engagement.
Great. Thank you so very much. So then we will go to Dr. Cruz, please. Would you mind unmuting, Dr. Cruz?
Yeah, I've been doing this all day. Thank you. My name is Dr. Mario Cruz. I'm a clinical professor of psychiatry at the University of New Mexico. I'm also the Director of Quality and Informatics within the Department of Psychiatry and Associate Chief Medical Information Officer for the University of New Mexico Health System. I've been in New Mexico now for 10 years. Previous to that, I was in Pittsburgh. Previous to that, I was in Arizona. Previous to that, I was in Crown Point, New Mexico, setting up mental health clinics on the Navajo Reservation. Presently, I am on the board of the WellStan Foundation, which is a new 501c3, whose goal is to improve the self-efficacy of Black children in the state of New Mexico. And I am the president of the New Mexico Black Wellness Coalition, a group of Black health professionals within the state of New Mexico, whose goal is to really provide networking and support for that group at this time. I felt it was important to participate in this to discuss the invisible nature of the African American community and make it more visible in the state of New Mexico. We have desperate needs for some, not all. But I think one of the things that we bring to the table is a long history of understanding white power and privilege, and the unfortunate consequences that that has caused in many of us. It has strengthened some, weakened others. And so I hope to provide some information, at least about the state of New Mexico in regards to this issue, and offer some opinions on what I think could help.
Well, thank you so very much. Now we will go to the Honorable Senator Jerry Ortiz-Pino, please.
Good afternoon, everyone. I am a social worker by training. I'm a retired social worker now after putting in 42 years working all of it in New Mexico. I'm a native of Santa Fe and have worked all over the state in Taos, Las Vegas, Santa Fe, Albuquerque, Las Cruces, and was first elected to the legislature in 2004. I'm running for what I think will be my last four-year term. If I'm elected, I will have served 20 years, and that should be enough for anybody. I currently serve as the chairman of the Senate Public Affairs Committee, which is where the health and the behavioral health issues all go. That's the starting point. If there's any legislative initiatives, any kind of scope of practice legislation goes there as well. And during the interim, I alternate as chairman with Representative Deborah Armstrong of the Interim Health and Human Services Committee. It's going to be a little unusual this year. We typically would have started meeting already by now, and we go around the state holding hearings, getting input from community members and program staff, trying to find out what are the issues that we should be dealing with in the legislature as they touch on health and human services. So I'll be able to share today some of last year's findings. We don't really know yet when we're going to get started this year. We're awaiting word, and we may have to do some of it virtually rather than going out in person to all the parts of the state as we typically do. But I'm very much looking forward to today and to hearing the questions and the concerns from people who are participating and from the other panelists.
Great. Thank you so very much. So I'm going to start with the question because in my role as a special project coordinator for the Secretary of Health, I am leading the efforts for testing in the minority communities, COVID-19 testing. So I've been with the state now for approximately 4 months. So that's interesting in and of itself, but I'm glad to be there. And I don't think that I'm there by accident. So it's good to go out into the communities to learn firsthand about some of the concerns that they have. Number one, around what COVID is and the education that we need to be providing in that regard, but also some of the barriers to testing. And what I hear constantly is this mistrust that people of color have for the government. Certainly, we know the obstacles and the challenges that we've had as Black people. So Mario and I can certainly talk about that, in our history. And I think each one of us has, our own stories as a part of our own culture too. But as a person who is going out into the community and trying to educate and trying to get people to test more, because we know we need to keep testing, particularly as the state continues to reopen after we have this pause that ends. What are some of the things that you think I need to say, and also other advocates for good, high quality healthcare need to say to the community at large, and why it's important to be tested? So let's go to Sarah first, and then anybody else who wants to jump in after that, please do.
Thank you for the question. So yeah, and definitely, working with marginalized populations or populations that have had challenges to have a voice in their healthcare and have that representation in healthcare. It is a challenge to understand and really buy into, the same system that is creating some of these inequities and disparities is then asking you to participate in it actively, right? And so being asked to get tested, coming from, the voice of the oppressor in some ways is really difficult. And so I think one way that we have had some success in encouraging testing for COVID is kind of coming, once you've built up that relationship of trust with patients and with families, I think that they're a lot more willing to see you as the bridge to that system and say, look, I'm here, I'm by your side rather than leading you. Let's empower you to kind of see your health in the bigger picture from the public health perspective. And, granted, we don't say all that in the right in the exam room, like, let's get you tested. But it is a way that we approach things, based on our relationship with families, based on the representation they see in providers that look like them or that at least understand some of them.
Great. Well, thank you. Who else wants to chime in on this? I see Teresa, you look like you want to. Okay, go ahead, Mario. I think we need to unmute. There we go. Mm-hmm.
You want to go first?
Yeah, go ahead, Mario. Go ahead, Mario. Mm-hmm.
Oh, okay. Well, I think one of the things that, and Sarah alluded to this, knowledge is power. And to be informed means you have some sense of agency and control over your destiny. And I think one of the things that in the New Mexico Black population that what seems to be good, at least I looked at the numbers today and I was shocked that in terms of number of that the COVID-19 cases are actually very low with respect to the total percentage of the population that we have, 1.93%. So I asked myself, we're doing pretty good on this side. What have we been doing? Well, one of the things I think we've been doing through the New Mexico Office of African American Affairs was having the weekly presentations from different experts in different areas of impact on COVID. The other thing was the outreach services, placing the testing services within already existing circumstances that people find comfortable to going to, particularly churches,
Yes.
APAC, the African American Performing Arts Center, and other places where people already feel comfortable going to. And so I think these kind of using natural systems and exploiting them as much as possible to reach out to people, to give them knowledge and understanding of the disease, to try to dispel some of the myths that occur as a consequence of the emotional toll that social isolation and what's been involved with COVID-19 in terms of restrictions has caused people. This is not anything new. Every pandemic, you see mistrust of major agencies and institutions. You see us versus them attitudes coming forward. The unfortunate event that happened with Mr. Floyd should have been anticipated under these circumstances, that some black man who was 6'4" or above was going to get killed by a white policeman. Everyone's been on edge. That was it, and it was the tipping point. So trying to use, I think, the existing places that people go to, feel trust with, and not trying to impose our will at all, and giving them knowledge that people can feel comfortable with. Now, the one good thing about video conferencing is that the intense emotional interaction between parties is lessened simply by the distance of wires. That can allow people to really cognitively think through whether what they're hearing is reasonable or unreasonable. It's no longer an emotional communication for the most part. It's a cognitive communication. I'm giving you information. You can then decide whether that information is valid or not from your perspective without my emotions being applied to you, where you then have to decipher all that information. So I think using all of these fancy tools, and African Americans have good internet connectivity, and we used existing centers, and we had people that, many of the people who are on the panels are on the lecture series, people already knew within the Black community. I think all of that combined helped have our rates as low as they are in this state compared to many other states where African Americans are dying at 6 times the higher rate, 6 times the rate of white Americans.
Yes, definitely so. Thank you. So today, so you want to talk about what's going on in the Native community, because we do know what we're seeing and what we're hearing, and I'd be interested, I'm sure the audience would love to hear your thoughts on how we're handling the whole COVID pandemic here in New Mexico.
Sure, and I did want to comment on your question, in that, you know, thinking about the mistrust and utilizing the systems that we usually don't trust, but in many circumstances they're the only systems that are available in a lot of our communities. You know, with the Indian Health Service to get, you know, tested and things like that, and I'd have to go back hundreds of years to talk about the structure of the health system for American Indians and the complexities of that system, and just the way that it was set up and how it's impacting American Indians and American Indian communities today. But I also want to say that I think a lot, in addition to the mistrust, there are so many structural barriers for American Indians and for American Indian communities, and for American Indians who rely heavily on the Indian Health Service and the Indian Health Service clinics that may be either in their community or near their community to get tested. And I think also we have to think about what happens when you're tested and your test comes back positive.
Yes.
Then what? We're talking about multi-generational families living in one household. We're talking about very close-knit communities. We're talking about in cases where many still very carrying out very traditional and ceremonial activities, very, very close-knit communities. So let's say, for example, have a household of 7 people and I'm tested positive. Where do I go?
Right.
Where do I get care? What happens to my family? What if I'm the primary, income earner in the family? What happens to my family when I get tested positive? And then we can spend probably the rest of the evening talking about the stigma that comes with that.
Yes.
And the stigma that all of our communities have faced over the years, that we're the ones bringing this and we're the ones spreading this, rather than, again, I think about, the examples that I use when thinking about the healthcare system that was designed for Native Americans, was originally housed in the 1800s in the Department of War. And really what was happening there was that the US government was wanting to protect the military from the Indians because they were afraid of disease. And so when you fast forward to today and you think about the structures and the barriers that Indian people have to jump through, not only the federal systems, but then thinking about, local systems and state government. And sometimes those communications aren't, I don't think, where either party wants them to be with, okay, we have an individual who's tested positive. Did they get their test through the IHS system? Is that system reporting to the state system? Did they get, is the state system talking to the federal system? And it's just, I think for me and my opinion for Native American people and communities, that a lot of it really goes back to that history, the structure, and then fast forwarding today on how complex it is to navigate that system. And that's coming from someone who has had to navigate that system. And had it not been for the networks and the expertise that I've gathered over the years, for the average person, it's so complex to just try to understand and figure out, where do I go?
Right.
And like I said, I get tested positive. Now what?
Right. And as you were speaking, I'm looking at everybody nod their head, because it's a common theme through, I think, every race that's represented here. Senator, you want to add any comments before we go to the chat and the questions?
Not really, Sonia. The answers that were given so far, I think, cover it really well. I don't have anything particular to add to that.
Okay, great. Well, thank you so very much, each of you, for sharing your thoughts on that. We may have some more questions that come up regarding COVID, but we do appreciate your insight. Manny, do we have any questions? Let's take a look and see what we got here. Do you see?
Yes, we do, actually.
Okay. You want to read it, or you want me to do it?
You could go ahead.
Okay. All right. So let me see. I'm gonna go to I'm going to go to the question here that we have. It says, is this time of heavy job loss, especially among minorities, a hint to us that we should move to something other than job-based health insurance? Interesting. How can we move away from that historical peculiarity? That's an interesting question. Did you get that, or do you want me to read it again? Got it? Okay. All right, then.
Let me jump in with what I'm hoping we can pass this during this 2021 legislative session, which is the Health Security Act. We've been tinkering with this for over 20 years here. Long before I was in the legislature, I was a lobbyist on behalf of what we called in those days New Mexicare. Now it's called the Health Security Act. And basically it would create a single pool of people in the state of New Mexico, independent of employment based. There would be a role for those employers who are currently providing insurance for their employees, but you wouldn't lose it if you lost that job or if you moved to a different employer. It would be created as a cooperative, and it would be a way for essentially New Mexico to eliminate the uncovered population, which even after the Affordable Care Act is still about 10%, 11% in the state, and now will be higher with the COVID and the people being laid off. So I think there is a way. I think the COVID pandemic absolutely points to the futility of trying to base healthcare coverage on on the basis of your employment status. It's not a good system. We should never have gotten into it. And here's an opportunity possibly to get New Mexico out of it. So we're hoping to see that realized during this upcoming session.
Well, it sounds like we have an opportunity to advocate for that. Does anybody else have anything that they would like to add?
I just wanted to add something that is alluded to as a result of the COVID pandemic. You know, it really did kind of uncover quite a few inequities that we've always known and seen and studied. But here now, right in front of us, right, you see that those who can't take, you know, paid leave, or those that are going to lose their employment will then lose their insurance, lose health care. Those that have no access to technology are not going to participate, you know, in all these great telehealth Zoom meetings and distance learning with their kids, and, you know, applications for unemployment and so on and so on. And so in every facet, including in healthcare and access to insurance, you saw the pandemic just really highlight those inequities. And so you know, the pandemic here isn't COVID, right? The pandemic is the institutionalized systemic cultural racism that underlies all of these systems.
Gotcha. Well, thank you. Okay. So I know that, you know, we're here to talk about inequities. So I certainly want to make sure that we do spend some time on that. So actually that was a very good segue, Sarah. So we're here to talk about the racial inequity in New Mexico's healthcare systems. So we probably need to talk a few moments about that. And so who wants to start, you know, with that? I come from the school of being voluntold, so I can do that. I can tell you who can go, if you want. So maybe we'll start with Mario this time. How about Mario? You give us your feel on New Mexico's healthcare system and the inequities.
Well, I do believe that there are inequities within the system for Black Americans, but not at the level of insurance. Looking at our health insurance level, we're doing actually pretty good. Where I think the trouble begins is accessing services that we all feel comfortable with. Herein lies some of the inequity within the industrial nature of our health system. We're predominantly providing secondary and tertiary services, not primary and early prevention services. And I think that what the area I would like to see targeted more is not when you have an illness, but before you get the illness. And we need many more prevention and early intervention services, not just for children, but also adults. when we look at the question of power and privilege in regards to that, it's not so much how the structure of the system's been created. Now, granted, secondary and tertiary services, the only people who can really afford them without any kind of break are the wealthy. The rest of us, we can't. You know, and within a pandemic like this, we now have reached the situation where we're going to have months, if not a couple of years, of continuing to have social restrictions. Whether people like it or not, that's what it's looking like. And that's if this virus works like, say, the Spanish flu virus in 1918, when 50 million people died. It lasted for 2 years and then died off. But this virus is different than the flu, and it's much peskier. And so it could be even longer that our new normal is going to be potentially wearing masks and social distancing and having quarantine and being restricted in terms of our social activities for a long time, unless a vaccine comes forward that works for all and lasts greater than what is occurring right now for individuals who have had coronavirus infections, and that's 30 to 45 days has been the longest.
Yeah.
So that's the reality of our future. These fissures that Sarah talked about and cracks within our system due to the way the structure of the system was initially conceived of is just going to grow. More people will be at the bottom. Fewer people will be in the middle, and there will still be those people at the top.
Gotcha.
And the notion of privilege is going to be an even greater issue in the future, unless something like Senator Ortiz Pino is talking about, that being actually creating a real net that is safe, that pulls us all in. I mean, the other issue that Sarah alluded to that we really have to talk about when it comes to health and well-being is the digital divide that was already beginning to occur prior to COVID-19, which is now showing itself even more in the ability, as Sarah mentioned, to access teleconferencing system, to have trainings, to get information on your own, so that you can then begin to have a sense of agency and judge what you think is truth versus what is fiction. And until we also combine not just a health safety net, but a digital safety net for everyone, such that everybody should have a smartphone. It's an absolute necessity these days. You can't live without one. Or a tablet, or a PC. They're all the same price now, it seems, but everyone should, in every home, should have access to that type of tool to be able to access the internet. It's just a necessity, and it's going to be even more so, particularly as this pandemic is going to continue. It's not going to go away in the next few months. It really isn't. And I'm not sure we're going to get a vaccine by the end of December, beginning of January. We may have to hang in there longer. So I think the reality is we're now seeing the social disconnection and incohesion within our society. We're seeing a stratification of wealth that's going to be stratified even further. We're going to see the bottom get bigger. And we're going to see more people needing services but having fewer means to get them. And so unless things like Senator Ortiz Pino is talking about occur, and unless we can really mobilize people to recognize that having access to the internet is essential for health and well-being these days, and every child deserves access, every adult needs access, and until we make those a right as well, I don't think we're going to be able to make it through what we're dealing with right now without a lot of, unfortunately, sad deaths from the despair of economic inequity.
Wow. So Teresa, how do we navigate this new normal? How do we navigate the inequity through this new normal that we have here?
Oh, wow. That's a very Good question. And I think something that we're all trying to tease through, but even thinking about, what Dr. Cruz said about that digital divide. And again, I'm going back to, reservation communities and frontier communities. That just doesn't, I mean, that divide is just getting bigger. It's like we're in the Grand Canyon right now. It's no longer a creek or a river or anything. I mean, we're talking major disparities when it comes to the digital divide. And I know that there have been many efforts for many years to try to, alleviate some of those problems. But, what we're seeing today is the significant reliance on needing to have not only a smartphone, but to actually get coverage without having to run down the street or to, like do kind of weird things or stand on your rooftop or something like that to even get coverage, much less having the broadband and the bandwidth to do things like telebehavioral health. And so, I think that again, I've been very fortunate that in all of the changes that we've seen in the way that healthcare is delivered, that I do have good internet, and that I'm in the city, and that I am close enough to my doctor's offices that I can easily get to appointments when I'm able to be seen. But that's definitely not the case for most of our tribal communities that have very limited availability of healthcare services right there in their community. And for those that aren't there in their community, then the access, getting transportation is a major issue. Is how do I get to my appointment? As I mentioned earlier, I'm a 2-time cancer survivor, and what COVID has forced right now is telebehavioral health, a lower priority. Even though I'm still on an oral chemotherapy, I'm on a lower priority because those priorities go to people who are on infusion chemotherapy. And then when you think about individuals who have to travel a long distance, and all of those barriers to just getting there and then getting back home and then figuring out, okay, now that I'm back home in my community, what happens when I need emergency care, or I need urgent care, or I need to have some kind of immediate care? What happens in those circumstances? And again, with the pandemic overlaying all of the barriers that we've already seen for many years, all the disparities and the barriers and the exacerbation of all of those with COVID. I really wish I had a good answer for you, and I know I'm just talking about
It's okay.
barriers, but I think we have to recognize and understand those barriers and the root causes of those barriers.
Yeah.
So that we can make good decisions about how do we even begin to address these barriers and the systemic barriers that have been in place for, in many cases, hundreds of years.
Yes.
I mean,
You're right.
We're thrown into this pandemic, and we're ill-equipped, no pun intended, to deal with our health.
Right. So I think having discussions like this certainly helps to spark that. But also, one of the things that we appreciate about our party is that we are a party of action. So that's why it's important to get the right people at the table. And as my sorority sister, Shirley Chisholm, said, you bring your own chair to make room at the table. I'm paraphrasing, but y'all know what I mean. You bring your own chair if there's not one there for you. And that's what I love about our party. Our party is a party of action. So I'm going to go to the chat to see if there is something here for us. Got some questions. Let's see here. Let me kind of go back up here.
We have one question from the chat, if you want to do that one, regarding the Supreme Court.
Yeah, okay, yeah, let's go to that one. Okay, all right. So what should the state do if the ACA is shot down by the U.S. Supreme Court and a large number of New Mexicans, especially minority members and largely adults, lose their health insurance? What should we do? Okay, Senator, yes.
Well, I believe that we have the opportunity then to do the Health Security Act, to implement that, which would immediately cover, much like the Medicare for All bill that Representative Jay Paul is proposing, it would cover everybody, and it would separate it out from private insurance. You know, one of the big dilemmas this country faces is that we've made healthcare part of a business model so that it becomes who can make the most money off of providing healthcare, which is precisely why our healthcare costs twice as much as most industrial nations' healthcare, and we get far poorer results. We've got to factor in all of the advertising and the profit margin and the administrative complexity that our system creates. So I would say that would add urgency to the need to implement the Health Security Act if the Supreme Court does strike down the Affordable Care Act. And of course, it depends on what parts of it they strike down.
Sure.
For New Mexico, the big benefit has been expanded Medicaid. And we went from 25% uncovered lives to 10, largely by picking up, an additional 10% of citizens in the Medicaid program. And the Medicaid program actually provides a pretty comprehensive system. The problem is the reimbursement for providers isn't as good as through private insurance. So many providers aren't enthusiastic about a Medicaid program. But I think that would be the only way we could respond effectively, would be to immediately pass something like the Health Security Act to pick up the slack and then incorporate the expanded Medicaid and to find a way to cover people who wouldn't be covered by their employer's insurance.
Gotcha. So what I'm hearing is there will be a call for action for us to make sure that when that bill is introduced, that we are doing our part to contact our legislatures to make sure that there is support for that. That's what I'm hearing you say. Absolutely, absolutely. So does anybody else, any of our providers want to add, to that? How do you think your patients will be impacted by that, if that goes away?
Well, in pediatrics, we definitely know that parents that do not have health insurance coverage or that lose their health insurance coverage, are less likely to bring their kids in for care or have trouble accessing the system, obviously for themselves, but also for children. And so, healthy families, healthy kids, the idea that we need to kind of create a safety net for families in New Mexico with our own state level legislation is just like the senator said, is much more important in the context of, ACA being threatened.
Gotcha. So, okay, all right. So let me see what else.
Do you want to take it one step further, Sonia, and address the access to care in regards to that question?
I think that'll be wonderful. So let's talk about access and any barriers to access. Let's talk about that. So let's go. Go ahead.
I'll jump in with something. that we struggled to deal with during our committee hearings, and that is the unavailability of healthcare professionals in many of these communities makes it very difficult for people to access healthcare. If there's only one doctor in town and he doesn't take Medicaid patients, you're flat out of luck. You might have good coverage. You may have Medicaid on paper would cover you, but there's just no way of accessing it. That's particularly keen in the area of behavioral health, where the last administration went out of its way to destroy our behavioral health system. The other implication there is that we have got to find a way to expand the pool of providers beyond just the currently licensed providers.
Okay.
We need to have a whole variety of culturally appropriate healthcare providers able to participate in our insurance program. If we're going to pay for it through insurance or through Medicaid, and those are the only two options we're giving people now, then we have to make sure that the insurance will pay for the promotoras, that will pay for the medicine men, that would pay for the people that are doing drug abuse treatment through non-traditional means. If they won't pay for it, it doesn't do us a whole lot of good to have that on paper, but then they don't pay for it. So my job this coming year in the legislature will be to try to break us free from the notion that only board certified physicians can do this, or only nurse practitioners who have been included in the MCO's network will be eligible for reimbursement. Let's break down those kind of artificial, administrative, unnecessary barriers and start opening up our system to the full range of healthcare providers.
I'd be interested in hearing the providers' opinion on that. I'm looking at you, Dr. Mario.
I agree. I think we need to have expanded health coverage to non-traditional health providers or clinicians. However, I think we also, when Senator Ortiz-Pino, when you had brought up the issue of culturally appropriate, I would like to go further in terms of that. It's interesting that the history of the cultural competency literature really began after the early 2000s. Before that, everyone was pushing for not just cultural appropriateness, but people of my same color taking care of me and expanding the pool of quote unquote board certified clinicians to include more diverse populations.
Yes.
And suddenly that became a non-issue anymore. And what came from that was cultural competency. The belief that there was no way that we were going to be able to meet the needs of the entire American population in all its various colors. So I think we need to really challenge our higher institutions of learning and ask, do you have few applicants who are colored? Or do you as institutions have unique and sometimes unconscious ways to discourage those individuals from applying? I don't think that question has ever been posed directly to the institutions of higher learning in this country. I've never heard it in the American Psychiatric Association either. So I'd like to see people be challenged to look at themselves. The only way institutional racism will go away is for people to begin to have self-awareness of how they in this system are perpetuating the system. And until we make that cognitive leap and begin to understand at not just a cognitive level, but at emotional level, that we in fact are the carpenters of this grand institution that has done a lot of good things, but for very few people.
Gotcha. Well, thank you for that. Well, you know, we're just like a family. Everybody has an opinion, but at the end of the day, we support one another, right?
You got it.
Absolutely. When you know better, you do better. So I think it's time now to go back to a question. Let's see what else we got here. Oh, this is a good one. Will each panelist please give an example of a systemic/institutional change which will address racial inequity in the particular field or profession each represents? And how does public policy help address this example? And will legislation be helpful in creating this racial inequity? That was a long one. I can read it again if you like, or did you get it? You got it? Okay, all right. So let's see here. Let's see. Teresa, you've been a little shy. So let's start with you.
Okay, and I did also see a comment in here from an individual who suggested or brought up the issue of making the Indian House Service more portable than it is. And I think that's definitely something that we could, that should be considered, because it is, even though the federal government has a trust responsibility to provide health care to American Indians, being able to access that health care is not as straightforward as it sounds. And so looking at the rules and regulations around how people can access the Indian health system is definitely an area that there needs to be a lot more thought put into that. But here's where the complicating factor comes in, is because the way the Indian health system works is that there are direct service tribes which receive services directly from the Indian Health Service, and there's also Public Law 638 tribes who obtain their funding from the Indian Health Service, but then they have full control over the services that they provide. And so I can give a real clear example, I hope. I'm from, as I mentioned earlier, I'm from the Pueblo of Isleta. I'm a tribal member. I live in Albuquerque. I am eligible to receive services, primary care, dental, pharmacy services through the Indian Health Service Clinic at Isleta Pueblo. A dear friend of mine who is also from one of the nearby pueblos, she's a tribal member and lives in Albuquerque. She cannot access services through her service unit because she lives outside of the boundaries that are set by that particular service unit. And so even though, like I said, it's a trust responsibility that the federal government provide health care for Native Americans, it's not that straightforward, because it really goes down to who's eligible to receive those services, where can they receive those services. And as we all know, we have a large urban Indian population in Albuquerque, about 50 or 60,000, and many of those individuals cannot access services through an Indian Health Service. They would have to rely on an urban Indian center like, say, First Choice community care. And so thinking about how that structure of Indian Health Service and how it talks to private insurance or Medicaid are really areas that we really need to take a look at. Even if an individual like myself has private insurance, or somebody that is eligible for Medicaid, and if we're eligible to receive services through Indian Health Service, Indian Health Service can bill my private insurance or Medicaid for those services that I would receive at an Indian Health Service. So it's really thinking about how those systems talk to each other or don't, and then figuring out how can we break down some of those barriers.
Gotcha.
And
Thank you so much. All right.
To Senator Ortiz-Pina's point, I also wanted to say that, you know, workforce, especially in the behavioral health world, and the significance of peer-to-peer support workers and being able to bill for those services, I think also is extremely important in thinking about building up the workforce. But when we think about providers providing services that look like us, we also need to think about those who have experienced the same things that we have experienced. And so I would put in a plug, Senator, for increased capacity for peer-to-peer community support, certified community support service workers.
Great, well, thank you. Dr. Sarah, if you don't remember the question, I can read it to you again.
Yeah, I think I remember the question. As in terms of some of the inequities we see amongst the families that we work with, you know, I echo everybody's statements in terms of the inequities run deep, and they are structural and systemic, and they are in all facets, right? It's in housing, it's in food access, it's in healthcare access, it's across the board in education access, all of that. And so one of the very specific things that I would like to see kind of made, you know, investments or more political will to move toward are these integrated, you know, kind of revisioning of what a healthcare clinic looks like, right? Along the same lines as what you were just saying, Teresa, is, you know, at our clinic, we have 8 doctors or medical, you know, it's a mix of nurse practitioners and physicians. And we have 14 social workers and therapists and home visitors and community support workers, and, you know, making that recognition that a family's well-being goes way beyond the ability to access amoxicillin or albuterol or things like that. It has to do with where you live, work, and play, and the kinds of advocacy efforts that your clinic and your medical home can help you navigate. And so one idea is you know, investing in more models like that bring community to the clinic and bring the clinic to the community. Another thought, you know, is now that we're looking a lot more closely at how systemic racism underlies, you know, so many different systems that contact families. Do we trust all of the research, you know, that looked at these biomedical models of who is, you know, supposed to be more impacted or who isn't, when those research studies were not necessarily done in the context of recognizing the structural racism or the cultural racism? And so, you know, should we invest in research that takes another look and says, well, yes, you know, groups are receiving inequitable care in these areas, but did you know the systems also are built this way, and, you know, kind of funnel families toward this type of experience? So those are just some thoughts on where you know, research can be funded to head towards looking at some of those root causes a little more closely and more comprehensively, and then also funding prevention and holistic kind of family care.
Great, but thank you so much. Dr. Mario, same question.
Well, I echo everything Sarah and Teresa said. They said it so eloquently, so I'm not going to even try to add to that. But the one thing I wanted to point out, and it seems like all of us are taking much more of a community-based, or what some other people may call a public health perspective, and challenging ourselves and looking at different variables that may have impact on the inaccessibility of healthcare and well-being. Mm. And so I had jotted down a couple of things while I was waiting to come on, and wanted to say after that, see. One of the things I think, besides looking at the structure and the access, is the appropriateness of the service. And accepting the notion that racism is real, it exists. It's not just going to go away by us turning our heads, but that we have to accept its presence, teach people how to learn how to cope with it, because it has not just psychological, emotional, educational, economic impacts, but it has physiologic impacts as well that increase the risk of morbidity and mortality in our populations. And so we have to have a system that can financially support looking at what might be considered non-traditional illnesses or non-traditional predictors of future illness. We need to fund more research into understanding not just how racial socialization can be a protective mechanism against some of these things, but come up with ways of understanding how proactive, protective, and adaptive socialization techniques can alter what are now like existing with within many of our communities, bad ways of dealing with the fact that you are low on the pole. And until we really start to address those fundamental beginnings of what are not just health issues, but what will be educational issues, legal issues, family problems, drugs, substance use, suicide, early demise of individuals, until we really address that as being a central tenet of healthcare. Mm-hmm. And trying to work on coming up with better ways of addressing those issues amongst each of our racial groups, I don't think we're going to move forward. It'll be like, you know, we're after the fact trying to address a problem that continuously assaults the individual rather than trying to address the assailant and how to cope with that assailant, because that assailant's not going to go away. They're going to exist, and we have to learn how to deal with it and not allow it to get in the way of people achieving the best they can in their lives.
Gotcha. Thank you for that. So, Senator, before you started your career in as a public servant, you said that you're a social worker. I'd be really interested in hearing more about some of your experiences in that realm, particularly as it relates to inequity in healthcare. So can you talk a little bit about some of the things that you experience in relation to the question as a social worker?
Sure, and the question asked, actually it's a nice combination, because the question asked to give an example of a systemic or institutional change that will address racial inequity in a particular field profession and how a public policy change might improve that. And the one that comes to mind is one that when I was a social worker, we ran into repeatedly, and as a legislator, we've seen constantly as well. And that is the issue of the school to prison pipeline. How kids who, for whatever reason, aren't considered to be cooperative, malleable, eager enough to learn, wind up getting kicked out and then become problems for our correction system, but also for our behavioral health system, ultimately may wind up becoming parents, without the means of supporting the kids, may become drug addicts, may become criminals of various sorts. And it really could all have been stopped early on if we had had a better response to their problems in school than simply kicking them out. And so I would love to see us do more about breaking that school to prison pipeline, because it's not just to prison, it's also to the drug and alcohol treatment system. It's also to the suicide system. In this society today, if you don't have at least a high school diploma, your chances of survival, let alone of flourishing, are greatly diminished. And so I think we saw shocking numbers in our interim committee of the number of kids that are suspended from school. And if your suspension lasts longer than 3 weeks, the chances of you finishing that year drop drastically. And if you don't finish that year, your chances of coming back to school drop even further. So what turns out to have been a 3-week suspension for some infraction winds up kicking the kid out of school and ruining his life forever. That has got to stop. We can't waste that precious resource of our young people. And we have ways of dealing with it. We have some wonderful alternative programs. Unfortunately, the easy way for a school system to deal with kids who aren't able to fully participate in the way that the school system wants them to is to say, you're out of here. We've got too many kids that want to learn for us to waste our time on you. You're done. But there are so many other things that could be done. And I just think we need to put resources into that group. we've got alternative educational models that really work well. I love the Job Corps, for example. For 40 years, I've been touting the Job Corps as one of the best ways of dealing with kids for whom the sitting in a classroom kind of learning doesn't particularly work well. We could have our own state version of a Job Corps in addition to the federal one. There are so many things we should be doing, but the easy way out is just to kick them out. And I think that's something we could deal with legislatively, stopping that and trying to come up with some alternative.
I think once again, you've given us a lot to certainly think about. I love the idea of coming up with alternatives to that. I don't know if anybody had a chance to participate in the listening session that the governor did last Friday on racial inequities, but a lot of what we talked about, or a lot of what was discussed was exactly what you're talking about, Senator, with how we need to have an alternative with how we are approaching the education system, particularly as it relates to brown and black kids, and how they fall into this situation where when something happens that they are expelled or suspended, and then they get further behind. So I do think that we need to find a way to discuss that, but moreover, come up with more solutions to have alternatives to that. So thank you so much, each of you all, for taking time to do that. I'm going to go to the chat room to see if there's anything else in the questions here. Let's see here. So access to care. Won't these issues be the same even if we get Medicare for all? That's an interesting question. So I'll read it again. Access to care. Won't these issues be the same even if we get Medicare for all? So who wants to start with that? Okay, all right, because I was going to volunteer you anyway, Senator.
Okay.
So okay, you can get started with that. Okay.
Well, you know, and I'm going to address it from the point of view of the Health Security Act, the New Mexico version of Medicare for all, because what we're proposing with the Health Security Act is that there would be a board, I think, of 18 members that would be geographically and politically and ethnically and racially diverse, that would be the ones that make the decisions about what services are reimbursed, what the reimbursement levels are, what kind of goals are set up for when we consider healthcare to have been well provided. And so I think that the key there is going to be to find reimbursement levels for all levels of providers. You know, we have a system now in which the specialists get particularly generous reimbursement levels. And so there's no real incentive for people coming out of medical school to get into general practice or primary care if they could become whatever, a radiologist or a brain surgeon or something like that, and get far better reimbursement for the time they spend. And so correcting that imbalance, I think, would be something that we could do with a single board that's making the decisions about reimbursement. Similarly for hospitals. The Health Security Act proposes global budgeting for hospitals in the rural communities. That means there's no particular incentive for the hospital to keep a patient longer, to duplicate services, to require more testing, to do more things, to simply churn the system and generate more profit, or not profit necessarily, but just survival money, because they would have a guaranteed global budget for the year. So I really do think that what we're talking about with Medicare for All is not just simply a payment mechanism, but a way of restructuring the whole system to put the focus on outcomes rather than procedures.
Gotcha. Thank you so much. Anybody want to add anything to that?
I wanted to add something just to go even further. Rather than focusing everything on reimbursement as it stands in a fee-for-service model, and then trying to redistribute or weight differently different specialties, I would prefer us to put the money around each person that has to be served, and then give that money to the providers and say, do with it as you see fit. That will lead to greater flexibility in the type of services or interventions provided. We may find housing being identified as a health issue, or food deserts being identified as health issues, and money, healthcare money being funneled to support overcoming those barriers that individuals have so that they don't go to the hospital.
Well, sounds like you have revolutionized the way that we may need to look at how we have high quality healthcare. Actually, that was one of the areas that came up in the chat room, and as I was monitoring, there was a question, or there was a conversation about how does all of this impact affordable housing and the whole rental assistance piece. So I think you've touched on that. I'd like to maybe explore that just a little bit more, because I think you're on to something, and I'm also trying to stay on time here too, because I know that we're going to have to start wrapping up shortly, but I think that's something worth exploring for a few moments at least. So I don't know if you wanted to add something else about that, Mario, or does somebody else want to talk about that, because it is a continuum. These are not siloed situations here. So
I just want to say, there are some good things in Arizona. When I was the chief medical officer for the county of Pima County around Tucson, Arizona had just started putting out value-based purchasing contracts for mental health services. And we down there, a bunch of young people saying, oh yeah, we're gonna take this money, we're gonna do some great things with it. So we got the money. And the money was based on how much money would you get per individual to serve. And you had a defined population you had to serve. And oh, we got very creative. We bought houses, we bought apartment complexes, gave people housing. We were able to, as a group, work with pharmaceutical companies to bring down the price of pills because we were controlling the county. And so it made life a lot easier in some respects. You didn't get very much money, but you also were allowed to be creative with the money. And so I think there has to be this delicate balance between regulatory decisions or regulatory issues that constrain providers in being creative and innovative, but also ensure a certain outcome, with allowing providers to be creative and innovative and coming up with new and different ways to ensure the health and well-being of populations so they don't go to a hospital.
gotcha. Okay. All right.
And I'll just add to that if I can. You know, a lot of times I'm looking at my patient schedule that day, and, you know, one particular example comes to mind. A mother brought in her child for his 4-year-old well child check, and come to find out he's up to date on immunizations. He had just gotten them. And so we're trying to dive a little deeper into what's the real reason for coming to your medical provider that day. And mom says it's the end of the month and we're being evicted and we can't pay our rent, and I didn't know where to go. So I came to the doctor's office. And so then you shift over to the social work team, and they arrange, you know, all these amazing things with the landlord and so forth. How do you bill for that type of service that you just did? We underwrite all of we used to underwrite all of our social worker salaries with the revenue from the medical side of the clinic. Now we underwrite the medical side with all of the contracts that we've obtained through city, state, CYFD, and county contracts to provide these difficult to compensate services. So thank goodness for these governmental contracts that allow us to take care of the families a little more comprehensively. It's just an interesting finding when we send, you know, the pediatric resident physicians to go learn about your patients, find out where the roots of their health, you know, access issues are, and they say, you know, Dr. Sada, I learned about tax reform all night. It had nothing to do with what they taught me in medical school, you know, or I learned about kind of, you know, other underlying root causes that all lead to my family that I'm taking care of unable to improve their well-being. And so until we kind of look at the big picture, you know, nothing that I can do in that medical kind of clinical exam room is going to be effective.
Right. Well, thank you for that. Let's see here. Yeah, go ahead,
I just
Teresa.
wanted to add real quickly is to, you know, to continue to remember that our communities have survived for hundreds and hundreds of years, and we're very resilient, and we know what our strengths are, and we know how to build on those strengths. And so making sure that in these conversations that we're having, that we're also having them in community, with community, and not at community. Because again, we know our people, regardless of if you're Native American, African American, whatever American you are, and you're a minority or people of color population, we're very resilient people. And we've survived some atrocities, we've survived genocide, we've survived a whole lot of things, but we need to go back to our communities, work on those strengths, and think about how it is that we have survived, and how it is that we continue to push forward.
Gotcha. Well, thank you so much. We have one more question in the chat room, and then we will have you answer those questions, whatever that question is. I think it's regarding COVID. I'm going to read it in a few moments, and then I'm going to turn it back over to Manny and Flora, you know, to wrap up. So I just want to say thank you so very much for your patience tonight and for answering all the questions. You all have been absolutely wonderful to do this. So let's see what our last question is. Let's see here. So it says worldwide reactions to COVID. This person says they saw a graph recently that showed different countries and levels of COVID illness and deaths in those countries. Countries with no cost healthcare systems had COVID rates that were down, whereas US had rates that are still high. Any observations from you in any way we could get systems that more reflect that kind of healthcare? So we're back at COVID. Yeah, Dr. Cruz.
Quickly, I was listening today on CNN, and they were saying that the U.S. has not been allowed to go to Europe. Nobody from the U.S.
I know,
but
my trip's
from
canceled.
Rwanda. But people from Rwanda can go. People from the Congo can go. That gives you that this is not an issue of money, and this is not an issue of centralized healthcare. Rwanda has a long history of setting up an incredibly well-designed public health infrastructure. And the Congo has as well, as they've been fighting the Ebola virus now for the past 7 years, 8 years. And so they immediately had community health workers out. They immediately, in Rwanda, had robots going to homes, handing people food. They had drones going out on contact tracing. They were using all these novel ways that are less expensive than what we have in terms of our incredible healthcare system, which does well in secondary and tertiary care. So if you need an ICU, we're the place to go. But if you don't want to get to an ICU, we're not the place to go. And so we really need a public health perspective, taking a much broader approach to this, putting our money in the community and not inside our healthcare systems. I firmly believe we're too wedded to this system now to disrupt it, and something from the outside is going to have to do it. And maybe COVID-19 will be that outside thing.
Gotcha.
Asia, you know, in Taiwan, they only had 230 people die from this ill. I think even test positive. The reason is because they have a culture of wear masks, distance, whenever you're sick. Everybody has taken that social contract and taken it to heart that this is what you do when you feel bad because you don't want to hurt anybody else. We need to change our view of our culture in terms of how we approach one another in that regards. So I'll shut up now and let everybody else talk.
Okay, who wants to jump into that too? Okay, Senator.
Just to follow up on that, I think that's clearly the case, that it's not because those countries that have done so well with COVID have great treatment programs, it's because, or a way of paying for them, it's because they have great public health programs that that respond more appropriately than ours did. But part of our problem, and in New Mexico, I just wanted to share that we will be spending more on Medicaid in the next year, almost $7 billion, as much as we spend on all the rest of the state budget combined. But that's because we consider the federal money coming in as well. But $7 billion on the treatment aspect, and our public health budget, I don't think is 1/100th of that. We really have got to rethink our priorities in terms of where we're going to put our emphasis, because we'll never get ahead of the ball game if we constantly respond to sickness by trying to provide more treatment. We've got to stop people getting sick, and that would be much wiser use of our resource.
Thank you so much. Okay, Teresa?
Ditto.
Okay, all right.
And I just want to reiterate what I said earlier, is that you know, we need to have the community as part of the conversation, and come up with, we know our communities have solutions to these issues that we're facing, and so again, let's make sure we have the communities involved in these solution-based conversations.
Great, thank you. So, Dr. Sarah, you have the last word on this.
Well, I do think that, you know, again, what everybody is saying, you know, the public health perspective is huge in taking care of, you know, being my brother's keeper in dealing with pandemics and systemic issues like that. This is probably the most momentum, you know, rather than taking the moment of having a COVID pandemic or the moment of Black Lives Matters protests and keeping the momentum going and making it a social movement beyond just this historic, you know, summer. And so this is exactly the time when we should look at what other countries' responses have been like to COVID pandemic, and what other places are doing in terms of public health perspectives and dismantling systems that just don't work. So looking forward to where the momentum takes us.
Yeah, great. Well, thank you. Thank you again so very much. Very interesting perspectives and a lot of good takeaways. I know I hear call to action for us as Democrats. Here we need to listen to the community and create forums for these communities. And not only that, we need to truly find a way to put those into actions. And again, we know as Democrats we can do that. So thank you again for your time. I want to turn it over to Manny and to Flora. And thank you.
Again, we wanted to say thank you, Sonia, for helping us with this. Thank you, Teresa Gomez, Dr. Mario Cruz, Senator Ortiz y Pino, Sara del Campo de Gonzalez. We really appreciate it. As you know, there are 3 notable health disparities in New Mexico, and they involve 3 high-ranking causes of death at this time. Deaths from heart disease, influenza, pneumonia, and diabetes, but these will change now with the new landscape with COVID-19. Health disparities exist along a variety of social dimensions in New Mexico, to the extent that the majority of New Mexicans may be affected. Advancing health equity is like going to improve health in New Mexico overall, and as well as improving it will also provide economic benefits to the state in the future, and that's why we have to continue to work together. But we can't rely on individual level interventions to make the gains in this health equity. Instead, population-based approaches that reduce poverty, improve the healthcare safety net, and address racial discrimination at the very root will be necessary to reap the health and economic benefits of healthy New Mexicans, and to also increase the equity. So thank you for having these very important discussions, and thank you all for being a part of this. Now I would like to turn it over to Flora, the chair for Democratic Party of Bernalillo County. And again, just want to thank you all panelists and all the participants out there for all the awesome questions. And just thank you for all your hard work you do. And continue to, put your best self out there, because New Mexicans need dependable healthcare. And just thank you for all you do, everybody. Thank you.
Thank you, Manny. We sure appreciate you being here and representing the party during this discussion. Sonia, you're excellent. Thank you so much for giving yourself to this.
Thank you.
I really appreciate your running this meeting, and to each one of you, I am so inspired and so grateful for the way you give yourselves to us to make this a better place. I just cannot tell you how deeply you have touched me tonight. So thank you for all you do, and thank you for being here and sharing yourself with us in this space. Attendees, I appreciate you. I appreciate your questions, your attention, and I appreciate the fact that I know you are committed to continuing this conversation, that this is not the end. This is not just 90 minutes of our lives. This is something that it takes our continued work. And as Dr. Cruz said, it takes each of us looking inside of ourselves to say, what is my part in this? What part do I play in contributing to systemic racism and into inequities, and what part can I play in making a change? So thank you all for being here, for being a part of this conversation, and until next time, be good, be well, be healthy.
Bye. Bye-bye.